Tim McCavit. I'm an assistant professor in pediatrics at UT Southwestern, and I'm pleased to be able to speak with you about this project entitled Survival into Adulthood in Sickle Cell Disease from the Dallas Newborn Cohort. We'll briefly introduce that sickle cell disease is a heterogeneous group of disorders, a hemoglobinopathy that is lifelong, a genetic condition that is associated with premature mortality. Previous survival estimates, and the most widely survival estimates, come from the cooperative study of sickle cell disease, which is an enormous cohort study performed in the 1980s in the US, and a Jamaican cohort also, which was followed primarily in the 1970s and 80s. And to give you some sense of the extent to which life was limited in these groups, the estimates were that men with the homozygous, which is the most common and most severe form of sickle cell disease, they're indicated as HBSS, survival was 44 years on average and 48 years in women. You can see the Jamaican estimates. However, inherent in these studies were significant limitations, and that is ascertainment bias. So these were studies which necessarily involved consenting this group of patients, and therefore likely excluded patients that were unlikely to be identified or enrolled. And then also survival bias. So they enrolled adults, and so by definition, there was a bias probably towards enhanced survival in those estimates. More recently, studies of survival have estimated actually somewhat decreased survival from these estimates in adults, and that's really what has driven us to look at a newborn inception cohort, and so that's what the Dallas Newborn Cohort is. It has been previously published twice, and it's an inception cohort. It includes patients with sickle cell disease who were identified by Texas newborn screening after October 31st, 1983, which was when newborn screening was instituted in the state of Texas. Patients in the cohort had to have been evaluated in our clinical program at least once and had to have one of the four most common sickle genotypes. We performed this update primarily to extend the survival analysis into adulthood. The previous analyses of this cohort essentially had stopped at the age of 18, which was when our clinical observation in our children's hospital concluded. We took two extra steps then to describe the survival into adulthood. We combed the medical records of the two adult hospitals, essentially that most of our patients are referred to when they transition to adult care. We also took advantage of a resource called the National Death Index, which I'll tell you a bit more about in 1 minute. To briefly get into the results, our cohort now includes 1,200 patients with 16,000 years of patient observation and follow-up, with a median follow-up of 13 years. The gender breakdown is, as expected, half female. And you can see the breakdown by genotype, so you can see that the severe genotypes of SS and S beta 0 constitute 2/3 of the cohort. The National Death Index is a resource that's made available through the National Center for Health Statistics. It essentially is a pooling of all of the bureaus of state vital statistics death reports from all states dating back to 1979. To use this resource, so many of these patients had left our center and we have no contact with them. And so to use this resource, we were a bit nervous not knowing kind of what the accuracy would be. You submit a bunch of identifiers and then they give you back a report saying these people are either alive or not alive. But we had the advantage of having 36 known deaths that we submitted, and we actually had a 95% sensitivity from the National Death Index in identifying people that we knew to be dead, which gave us more confidence in the submission of these 606 unknowns in which 9 patients were identified to be dead. So these then are the actual first ever survival estimates from a newborn cohort for individuals with sickle cell disease. And you can see that survival for all-cause mortality for individuals, and this is all genotypes, that all-cause mortality at the age of 25 is 91%. I'll point out to you that the number at risk at the big step-off at age 30 is quite low, and so I would just ask that you cautiously interpret the large step-off because we have such a small number at risk at that age. This figure shows the all-cause mortality by birth cohort, and we do see a non-statistically significant but continued improvement in survival based on birth cohort. So you can see that this, the blue line, which indicates the birth cohort for children born before 1990, does have worse survival compared to those born in the 90s and then those born after. We performed Cox proportional hazard modeling for the predictors of early mortality that we had available. Those included steady-state hemoglobin, so you can see that a lower steady-state hemoglobin was associated with an increased likelihood of early mortality, as was the severe genotype and a lower steady-state oxygen saturation. In multivariate modeling, only steady-state hemoglobin, a lower steady-state hemoglobin was actually associated with an increased risk of death. So we are excited about these studies, and in the primary presentation tomorrow we'll detail our ideas for how to move this forward. I think the way we would interpret this, it actually depends on how you want to view it. So we're quite pleased that a disease that has historically been associated with actually death in childhood, we're now demonstrating survival of over 95%, 90%, 95% into adulthood. And we're not seeing the degree of acceleration of mortality that one might have expected in early adulthood. Nevertheless, the acceleration that we do see is concerning, and we think merits a lot of focus on this 15 to 25-year-old age range. Thank you.